Be talking on post-AI and CDK4/6 inhibitor, what fits in the HER2 positive, hormone receptor positive, HER2 negative breast cancer landscapes. Please come to the dais.
So, good evening, everyone. Thank you so much, BICC, for inviting me here in Dhaka, and I would like to say thanks to the Beacon Pharma for giving me opportunity to share my thoughts on post-CDK4/6 inhibitor, what fits in hormone receptor positive, HER2 neu negative, metastatic breast cancers. I'm Afzal, medical oncologist. Nothing to disclose. So in next 30 minutes, I'm going to talk about the goals of the patients with metastatic breast cancer, what is the new post-progression CDK4/6 inhibitors, what we in LMIC country have, and what are our limitations, and what are the evidence-based practice that we can do in resource-limited setup. So whenever we are treating a patient with a stage 4 disease or any kind of a metastatic patient, whether breast cancer or any other type of a cancer, our goal is to maintain the quality of life without compromising the survival. And when the goal is just to improve the survival without compromising the quality of life, we have to look certain factors before deciding any sort of a treatment. What I used to do, patient factor, disease factor. Patient factor means patient age, performance status, patient quality of life at that point in time, patient preference, the most importantly, and the economics as well. And we have to look into the biology of the disease as well. If we talk about the breast cancer, the triple negative is the aggressive one, HER2 positive is mediocre, and hormone receptor positive is a good disease to have it. So for decades, the hormone receptor positive metastatic breast cancers, AI or hormonal therapy was the standard of care treatment till 2015-16, when the landmark studies with the names of Paloma, Mona Lisa, and Monarch were published, and they established the role of CDK4/6 inhibitor in the metastatic setting. And after that, there is a list of drugs that have come to play an important role in the management of breast cancer patients. So quickly, review of what is CDK4/6 inhibitor. Normally the cells have cyclin-dependent kinases, and when the cyclin-dependent kinases becomes activated, it causes phosphorylation, or it inhibits the retinoblastoma protein to get phosphorylated. So CDK4/6 inhibitor inhibits these cyclin-dependent kinases, and it allows the retinoblastoma to get phosphorylated, and when it gets phosphorylated, it inhibits the cell from G1 phase to enter into the S phase. So there are three different kinds of CDK4/6 inhibitors, the palbociclib, abemaciclib, and ribociclib. All they are different in terms of their molecular structure, their biological half-life, and in terms of CNS penetration. Abema is the only CDK4/6 inhibitor which has a CNS penetration. The rest of them, like Palbo and Ribo, doesn't have this CNS penetration. And Abema is unique in terms it has to be taken at a continuous dose, daily dosing base, while the Palbo and Ribo have to be taken at 3 weekly on, 1 week off dose scheduling. So from the trials, Paloma, you can see that from the Paloma, Mona Lisa, Monarch, all these trials have shown that there was a statistically significant progression-free survival benefit when CDK4/6 inhibitor was used with combination of AI in first-line setting. Does this benefit turns into the overall survival? So we know from the data from the Mona Lisa 2 and Mona Lisa 7, which is the ribociclib trials along with AI, that these drugs translate this progression-free survival benefit into the overall survival benefit. For the majority of the cancers, when we talk about the new drug or any kind of a drug, we talk about the overall survival benefit. But for hormone receptor positive metastatic breast cancer, it's a slow-growing disease, we know. So any drug that increases the progression-free survival plays an important role in the treatment algorithm. So So this is the same even for those who have an endocrine resistance. So patients who develop disease progression within 12 months of starting endocrine therapy, they are usually called as endocrine resistance. So even in those patients, CDK4/6 inhibitor, the ribociclib have shown OS benefit. So and if you look at the Paloma 3 trial, which was a trial for palbociclib, it shows that there wasn't a trend of overall survival benefit, but it does not mature into the statistically significant level because of the various reasons. So before moving to the what next after the CDK4/6 inhibitor, just brainstorming. If a patient comes to your clinic and she is a 55-year-old female with metastatic hormone receptor positive breast cancer and she has been progressed on CDK4/6 and AI, what will you do? Any question? Any guess? Any answer? Patients with metastatic hormone receptor positive progress on CDK4/6 inhibitor and AI, what will you do? Will you give another CDK4/6 inhibitor? Will you change the partner? Will you give it the chemotherapy? What will you do? Any guess, my dears? You will change the treatment. Okay. So what I used to do in my setup and what is recommended, if possible, is to get a biopsy done. Why biopsy done? Why tissue biopsy or liquid biopsy done? So we know that when there is a disease progression, there is an alternating pathways downstream that become activated, and now they are the driver mutations, and by which we can, if target, we can control the burden of the disease, and we can further limit the spread of the disease. So whenever you have a patient with hormone receptor positive or any type of a cancer, like in breast cancer, any 3 types of a cancer, we heard the terminology called receptor discordance. In hormone receptor positive patients, approximately 15% of the patients may have receptor discordance. But the most importantly, the reason for doing the repeat biopsy and doing NGS testing is to find out the mutation, which is the actionable mutation by which we can target. Most commonly, 30% of the cases we have ESR1 mutation, followed by PIK3, AKT, PTEN, and roughly about 5 to 10% of the patients have germline BRCA mutation. So whenever you have a disease progression on CDK4/6 inhibitor, it is wise to get a biopsy done if possible. If not, then do a ctDNA testing for finding an actionable mutation. So these are the alternative pathways. You can see a downstream pathway, AKT, mTOR pathway, and there are different drugs available to target that activating pathways. So the first trial that I'm going to share with you guys is the Emerald trial, which was a randomized phase 3 trial that was done that was a multi-center randomized phase 3 study done in postmenopausal women who have been progressed on CDK4/6 inhibitor with AI. So it was the patients were stratified into 2 groups, randomized into 2 groups. One arm received elacestrant 400 milligram once daily dose versus physician's choice. Mostly of the patient in the physician choice arm received fulvestrant. And the primary endpoint of this study is to see the progression-free survival in all population, and the co-primary endpoint is to see the progression-free survival in ESR mutant group. So patients were stratified based on the ESR mutant versus non-mutant. If you look at the progression-free survival of intention to treat population, which is on your left side, so it was shown that progression-free survival was benefit in all the subgroup. But does this progression-free survival benefit is statistically significant? It was not. But if you look at the right-sided graph, you can see the graph lines are very well separated from each other, and the p-value and the hazard ratio is statistically significant. The median progression-free survival at 12 months was 26.8% in elacestrant group versus 8.4% in standard of care treatment, which was the fulvestrant. So patients who are harboring ESR1 mutation, they do well on elacestrant based on the Emerald study. They do the subgroup analysis, and they found that the patients who are endocrine sensitive, like those who had a progression of disease after 12 months, the benefit was more. If you look at the numbers, for patients who have 12 months or more CDK4/6 treatment, their hazard ratio is 0.44 to 0.41 to 0.44 versus those who have early disease progression. So that means patients who are endocrine sensitive or those who have been on CDK4/6 inhibitor for more than 12 months, they are the one who may respond better with elacestrant with ESR mutation. There is another study which was published in, which was discussed this year, ASMO, in which they look at the patients who are on the CDK4/6 inhibitor with AI. They do the ctDNA analysis, and if they found to have an ESR1 mutation without progression, they switched them to the camizestrant, which is another SERD inhibitor, and this trial was a SERENA trial. In Emerald trial, the drug was very well tolerated. Approximately 8% of the patients patient needs anti-nausea vomiting medication, which was the most common side effect of the elacestrant. The second pathway, the most common pathway, is PIK3 AKT-mTOR pathway, PIK3CA AKT pathway. So alpelisib is the drug which was used in combination with fulvestrant in SOLAR-1 trial. This was a randomized open-label phase 3 trial in which patients were randomized to two groups. One has a PIK3 mutant, one has PIK3 non-mutant. The SOLAR-1 trial basically looked at the data of the PIK3 mutant group, and in that mutant group, the patients were further randomized into two arms. One arm received alpelisib plus fulvestrant versus fulvestrant with placebo. And all these patients are those who have been progressed on CDK4/6 inhibitors and AI and may have received one or more lines of chemotherapy or, and have analytic lesions in the bone as well. The primary endpoint of this study, the SOLAR-1 study, is to look at the progression-free survival in PIK3 mutant cohort only, while the secondary endpoint was the overall survival. If you look at the primary endpoint in terms of PFS, it was better in patients who received alpelisib with fulvestrant. It was about 11 months versus those who received fulvestrant plus fulvestrant plus placebo, which is about 5.7 months, with a hazard ratio of 0.65, with statistically significant p-value and a good confidence interval. If we talk about the overall survival, for at least 5-year follow-up, alpelisib plus fulvestrant combination showed that there isn't a trend of improved overall survival with combination of alpelisib with fulvestrant, which is about 39.3 months versus 31.4 months. Although this was statistically non-significant, numerically it was significant because after the progression, the placebo arm have different drugs that can be used and that nullify the benefit that one can have with alpelisib plus fulvestrant. If we look at the subgroup analysis, patients who have been progressed on CDK4/6 inhibitor, whether they have been progressed on CDK4/6 inhibitor or they haven't used the CDK4/6 inhibitor, all the subgroup did well. But overall survival was numerically and statistically more in patients who have lung and liver metastases with PIK3 mutant, with median overall survival prolongation by 14 months in patients who receive alpelisib plus fulvestrant. The most common side effect that alpelisib may have is impaired blood sugar levels. So before starting your treatment, you must check the HbA1c or you must check the blood sugar levels because alpelisib is not a good drug to give to patients who are diabetic. The third trial that I'm going to present is the Capitilo trial, in which basically inhibit the AKT pathway. And in this trial, the drug is capivasertib, 400 milligram twice daily, 4 days on, 3 days off. This was a randomized phase 3 trial in which patients who have been progressed on CDK4/6 inhibitor and they have received 2 or more lines of treatment, they were randomized to receive capivasertib versus fulvestrant, and the randomization again was done based on patients who have AKT mutation versus not. The Capitolo trial basically looked at the data of patients who have AKT mutation. The primary endpoint of this Capitolo trial is the progression-free survival in overall population and the AKT pathway mutated population, and the secondary endpoint was the overall survival. So yeah, so dual primary endpoint, PFS in overall population and AKT pathway selected population. So if you look at the overall population, capivasertib plus fulvestrant did well with numerically increase of roughly a 2 months PFS benefit as compared to the placebo with fulvestrant, and the hazard ratio is statistically significant 0.60. But if you look at the AKT pathway, alteration pathway, the hazard ratio is 0.50, means it reduces the chance of disease progression by half, 50% of the patient, 50% of the chance that it will reduces the disease progression. And if we talk about the numbers, 7.3 versus 3.1 months. The last trial that was discussed this year in ASMO conference was a TROPIC-2 trial in which sacituzumab govitecan was tested in locally advanced, inoperable, metastatic hormone receptor positive breast cancers. So sacituzumab is govitecan is an antibody drug conjugate which was initially used in triple negative breast cancer, but now it has been tested in hormone receptor positive HER2 metastatic breast cancer, those who have been progressed on CDK4/6 inhibitors and have received prior lines of treatment. The randomization is 1:1. One arm received the antibody drug conjugate SASI, and one arm received physician choice treatment. Primary endpoint was the progression-free survival. So the TROPIC trial shows that progression-free survival at 6 months, 9 months, and 12 months was consistently improved as compared to the physician choice for metastatic breast cancer hormone receptor positive who have been used prior lines of treatment. And it also shows that there wasn't a trend of improvement in overall survival data, but we need to follow up this for a longer period of time to have a mature data. These are all the fancy drugs that are available in the West. Do we have all these drugs available in Bangladesh? I must say in Pakistan, majority of the drug, like we don't have capivasertib, we don't have elacestrant, we do have alpelisib, but through a gray channel. So the question is, what are the alternative evidence-based treatment options available for us, like low middle income countries? So can we use CDK4/6 inhibitor post-progression? Yeah, there is no data. There are 2 trials, post-MONARCH trial and the MAINTAIN trial. In the MAINTAIN trial, addition of ribociclib to endocrine therapy post-progression have shown that it improves the progression-free survival by a couple of months, like 3 months. In the MAINTAIN trial, the majority of the patients that were included in this trial have previously received palbociclib. So they were switched to ribociclib along with switching of endocrine therapy. And it shows that it improves the progression-free survival by 3 months. And there is another trial, post-MONARCH trial, in which patients who have been progressed on palbociclib or ribociclib, they were switched to the abemaciclib. Can we combine the mTOR inhibitor with AI? Yes, we have a Bolero-2 trial in which everolimus with exemestane was combined, and it was compared with placebo. And it shows that the primary endpoint of this study was the progression-free survival, and secondary endpoint was the overall survival. And it shows that the combination of exemestane with everolimus improves the progression-free survival and with a hazard ratio of 0.45, and improves the overall survival at long-term follow-up of almost 5 years. So these are the options that in low middle income countries we have. And honestly speaking, in my clinical practice, when I got stuck with my patients, I used to follow these trial recommendations. Then there is another trial in which fulvestrant plus everolimus combination can be used. I used to do in my patients who have been progressed on CDK4/6 inhibitor, I usually switch them if they can't afford the biopsy or tissue testing. I usually switch them to the another pathway inhibitors like mTOR inhibitor, everolimus, and fulvestrant. And this was in a pre-0102 study, which was in a phase 2 study, and it shows that by putting the patients in fulvestrant plus everolimus combinations, not only improve the progression-free survival, but also improves the quality of life as well. For patients who have germline mutations, we have two trials, UMBRECA trial and the Olympiad trial, in which PARP inhibitors can be used. And both of these trials have a different population, different PARP inhibitors used. Olympia use olaparib, while UMBRECA use talazoparib. I haven't used the talazoparib because it was not available. If I get the chance, we used to put the patient on olaparib. Both of these trials have shown that median progression-free survival may improve with addition of PARP inhibitors, olaparib or talazoparib, as compared to the placebo. So the take-home point from this all of these trials is to check the molecular status when you have a disease progression on CDK4/6 inhibitor, and the most common mutation is ESR1, PIK3, and followed by AKT and HER2 amplification you may see. Improvement in progression-free survival highlights how the precision medicine is transforming the cancer care, and a collaborative effort should be made with compassionate access programs and local manufacturings help to overcome the barriers that LMIC have usually faced. Because most of the drugs, the generic drugs that are not available, if the pharmaceutical companies used to make these drugs locally at our part of the world, the cost will be reduced and cost will be cut down. So the drugs will be available, and we have more drugs available in terms of the treatment options. I would like to acknowledge my teacher, my spiritual ma, Dr. Azmina Tajuddin, whom I learned a lot, and I know how to treat the breast cancers. When I was a resident, I was thinking the breast cancer is the easiest cancer to treat because there is nothing like AC followed by Taxol. But she was the one who taught me that breast cancer is in a whole big story, and you have to individualize the care by looking at the biology, looking at the patient. So she taught me how to treat the breast cancer and other cancers. So I used to call her my spiritual ma, the mother. And not only the science she teach me the arts of oncology as well. So I really acknowledge her. Thank you so much for patient listening. Thank you.
So thank you so much, Dr. Afzal, for your wonderful talk. Now the time for the panelist, and I always love to grill my panelist.